Welcome to Master USMLE. Hello, future doctors. Welcome back to Master USMLE, the podcast that simplifies high-yield concepts for your USMLE Step 2 CK success. I'm Dr. Ami Nafrasyabi, and today we're diving into a classic renal case that will test your diagnostic skills and prepare you for exam day. Picture this. A young man walks into your clinic with tea-colored urine. What's going on? Is it infection, kidney disease, or something else? Let's break it down and get to the answer. The case. Sudden hematuria. After a cold. A 22-year-old male presents with dark-colored urine that started this morning. He recently recovered from a mild sore throat and congestion that lasted a few days. No fevers, no antibiotics, just some NSAIDs for mild pain. He has no significant past medical history and takes no daily medications. Vitals. Blood pressure, 145 over 90 millimeters of mercury. Heart rate, 80 beats per minute. Temperature, 37.7 degrees Celsius, 99.9 degrees Fahrenheit. Physical exam shows no edema, no rash, and no joint pain. However, his urine analysis tells a different story. Urinalysis. Blood, large. Protein, 1 plus. RBC, casts present serum. Chemistry, creatinine, 1.4 milligrams per deciliter. C3, C4 complement levels. Normal. What's your diagnosis? Step-by-step clinical reasoning. A young patient with gross hematuria after a respiratory infection raises suspicion for a glomerular cause of hematuria. We need to differentiate between the key possibilities. Acute post-streptococcal glomerulonephritis, APSGN, appears weeks after a streptococcal throat or skin infection. Low C3 due to immune complex deposition. Presents with periorbital edema, hypertension, and gross hematuria. Biopsy shows subepithelial immune complex deposits, humps. IgA nephropathy, Berger's disease. The correct answer appears within days of a viral infection, synpharyngitic hematuria. Normal complement levels. IgA does not activate complement significantly. Recurrent hematuria, possible mild hypertension. Biopsy shows mesangial IgA deposition. Key exam. Tip: if a patient has normal complement levels and hematuria that starts almost immediately after an upper respiratory infection, IgA nephropathy is the most likely diagnosis. The science behind IgA nephropathy. IgA nephropathy is the most common glomerulonephritis worldwide. It results from IgA immune complex deposition in the mesangium, triggering inflammation and leading to recurrent episodes of hematuria. Risk factors. For progression to chronic kidney disease. CKD. Persistent proteinuria greater than 1 gram per day. Uncontrolled hypertension. Declining renal function over time. Some patients remain stable for years while others progress to end-stage renal disease. Diagnosis and workup. Urinalysis. Proteinuria, hematuria, RBC casts, serum creatinine, elevated in progressive disease, complement levels, C3, C4, normal in IgA nephropathy. Definitive test, kidney biopsy. O findings, mesangial. IgA deposits a useful mnemonic. IgA, immediate gross hematuria after infection. Treatment and management low-risk patients. Normal blood pressure, minimal proteinuria. ACE inhibitors or ARBs to reduce proteinuria and control blood pressure. High-risk patients, proteinuria greater than 1 gram per day, worsening kidney function. Corticosteroids to reduce mesangial inflammation. Immunosuppressants in select cases. End-stage renal disease, ESRD. Dialysis. Kidney transplant. IgA nephropathy can recur post-transplant. Most cases are mild, but patients with significant proteinuria and hypertension require aggressive management to prevent CKD. USMLE Step 2 CK Challenge Question. A 20-year-old male presents with recurrent episodes of gross hematuria that begin a day or two after colds. His blood pressure is 145 over 90 millimeters of mercury, and labs show urinalysis. Proteinuria, 1 plus TR. RBC cast present serum chemistry. Serum C3 and C4. Normal. Which of the following is the most likely diagnosis? A. Subepithelial immune complex deposits. B. Mesangial IgA deposition. C. Linear IgG deposition along the glomerular basement membrane. D. Fibrin deposits with crescent formation. The correct answer is B. Mesangial IgA deposition, which is classic for IgA nephropathy. Final rapid review. IgA nephropathy presents with recurrent gross hematuria immediately after viral infections. Normal complement levels. C3, C4 help differentiate it from APSGN. Kidney biopsy shows mesangial, IgA deposits, ACE inhibitors, steroids, and blood pressure control. Slow progression. High-risk patients need close follow-up for CKD risk closing remarks. And that's a wrap for today's episode of Master USMLE. We covered a classic nephrology case that's a must-know for Step 2 CK. If you found this helpful, make sure to subscribe and share. Follow us for more high-yield breakdowns to help you master the USMLE with confidence. Until next time, keep studying and stay focused.